So, obviously we do see a fair amount of patients with things like maybe Parkinson's, MS, strokes. When would it be a good time to refer someone to a neurophysio? And, if we've got a stroke patient that's maybe years down the track of stroke patients and hasn't had that probably good neuro rehab, can they still get benefits? When should we be referring and a patient?
Thanks, Katie, and I get that question a lot of times from people who want to refer. As a therapist, I am obviously optimistic, but also the reality is that neuroplasticity exists. So there's always the potential for change in a system depending on what information it's getting and receiving and what's happening. So if you can drive some afferent information, you can hopefully drive some change. So I mean, yes, obviously, the earlier, then you don't have some of those established patterns, established wiring to support those patterns of movement. So the earlier, I guess, the better. But sometimes, in fact, that's not always the case, particularly in the early stages. Sometimes people aren't ready, or if they've had a hemorrhagic event, sometimes actually a little bit later they can, not that they don't need it early, but they can actually really take it on board and benefit later. So I would say there's always potential for change, and it's never too late to try and change movement behaviour. Well, there's another part of the question.
Well, is there certain, I guess, was it anyone with an alternate gait, would they benefit? Is there a certain time or person that would suit better?
If they want to improve, if they think, this is bothering me, it's not easy enough, it's limiting my function, then I'd say, all right, refer and let's see what we can do. Because possibly if there's the analysis to problem solve what might be driving the inappropriate activity, is there something that we can give you to drive more appropriate activity, then yes, we could potentially change it.
Would anyone like to comment on restless legs syndrome? Is there any relation to this or not? Any comment, please?
We share a patient. So restless legs, if I'd had time, I could have covered that in my peripheral neuropathy talk, because it is one of the things that sometimes comes along with people thinking they might have peripheral neuropathy, because often they have prominent sensory complaints. And the difference between that and neuropathy is that the sensory complaints pretty much are always, but mainly between the knee and the ankle rather than in the foot. And patients quite often talk about their pain or their crawling sensations or their sensory symptoms in a way which doesn't give away the fact that these things happen when they're sitting down and resting or relaxing. They sort of gloss over the fact that the symptoms go away when they get up and move around. So it's always important when people come with slightly strange sensory complaints, particularly if they haven't really localised them carefully, just say, well, okay, when is it bothering you most? What happens when you get up and move around? I'm sure you ask those questions because they're important to you, but it's usually then that it becomes evident, this is the problem that occurs when they're at rest, and it gets better when they move around. So is that talking partly about your question? Do you want to know anything? What do I think is going on? I don't know. People with restless, I think probably is an issue likely happening in the spinal cord. We know that restless legs has quite a strong familial basis. We know it's common in pregnancy, it's common with iron deficiency, and it's common with other things which are damaging peripheral nerves like diabetes and renal disease. So there are other metabolic issues perhaps. The fact that it responds to a different range of medications is interesting. It responds to dopamine agonist medication quite well, which is medications we use for treating Parkinson's disease. So it suggests that the dopaminergic pathway might be important, and certainly people with Parkinson's disease often get restless leg syndrome. There are some evidence that some spinal reflexes might be slightly overactive in restless leg syndrome, but really I don't have a clear understanding of what the underlying physiology is. Have you got any idea?
certainly not, Chris. I think, though, one of the interesting things about restless legs is that it illustrates the point that Libby made, and I also made as well, and that Chris has actually just alluded to. These people's symptoms, it goes away when they start moving around. And it's actually remarkable that, because, certainly, unfortunately, people with CRPS, their pain often doesn't go away when they start moving around. It does quite the opposite, which is one of the great difficulties in treating it. So, quite what's going on. I mean, we're all a bit in the dark here, and certainly the response to dopamine agonists can be quite good, but even that's a bit of a mystery. As far as we can go, I guess.
I think the thing to say is fortunately, probably these days, if you make sure their iron levels are adequate, they've got a good ferritin level, generally speaking, most people, not all, will get a reasonable response to one medication or another. So the days when really they had to put up with it and couldn't find anything that worked for them, they're probably gone. So I mean, things like dopamine agonists, things like pregabalin, sometimes other medications, do seem to give most people a reasonable benefit. Sometimes in severe cases, you're chasing your tail, and actually the dopamine agonists sometimes lead to a bit of wind-up where it actually spreads to other parts of their body, and that can become very troublesome. But 90% of the time, it probably is pretty easily managed.
All right, well, I've been a terrible timekeeper because I found that all very interesting. Oh, we've got one more question? No? And, oh yes, all right, sneaky.
Jane had physiotherapy has been one of the beneficial interventions in your treatment. I was just wondering if you could elaborate a bit more on what sort of physiotherapy you've done.
Oh, look, I think there's been a few different layers there. One is that Jenny's been an absolutely remarkable listener and has helped me begin to demystify some of these things going on. She's also worked in a wonderful way with the rest of my team. So I've had that real multidisciplinary team going. And I guess in terms of what actual physical therapy I've had has varied. I mean, at the moment I see her twice a week, and she just does some very gentle massage and gets the knots out of wherever the pain seems to be at the moment. So at the moment it's hanging around up through my calf. So just that little bit of massage really helps me keep going. Look, the pain's a shapeshifter, so she'll just do whatever massage with those magic physio fingers, of wherever she needs to. I guess I also work with her in the pool a couple of times a week, so that's been really beneficial, and I've learnt lots about movement and things that I can do to help myself in that way. And I've also got exercises that I can do at home that she's taught me. So it's been lots of different things that she's been able to bring to my world. But certainly that notion of being very much of a multidisciplinary team has been immensely helpful. She's helped me with the language too, the words and to understand. I don't have any medical training apart from first aid training for school. I can put your arm in a sling, but, I don't know. I'm not medically trained, so this is a whole new language base for me. So Jenny and Nigel Rowe have sort of helped me understand all of that.
Yeah.